Thank you guys so much for coming here and spending a little bit of your time here at AWU with us. But I'll let the lady go first to introduce herself.
Thank you. I'm Greta Vladinov. I'm the program director of the Nurse Anesthesia program for University of Miami School of Nursing and Health Studies.
Yeah, and I'm Douglas Fajardo. I'm the CEO of Xennial Digital. And our goal today is to show you, how we're thinking and how we're implementing already a transition from single simulation applications into a full-blown product that we're calling the Medical Verse. So excited to share this with you today. So just as an intro, we're based in Miami. We are a team of over 30 people. Very focused, especially in the simulation side on using purely virtual reality. And with the University of Miami, both at the School of Nursing, but as well as the School of Medicine, we're starting to do a very close collaboration where we are actually productizing the solutions that we're building and are starting to be implemented into our schools of medicine across the country. So one of the reasons that we decided to focus on this specific area was because even before COVID and after COVID, one of the most pressing challenges in the healthcare space is the fact that the demand for medical professionals is just exceeding supply. And that it was happening even before COVID. So where you see that number 80,000 plus, that was more than 80,000 applicants into just schools of nursing that got rejected because of lack of space, physical space, and physical simulation space. If you also go today on Indeed.com and look for nursing jobs available, there's over 1 million positions available. So the issue just continues to get worse, and we've seen that a major part of that is just physical space is not scalable at schools at medicine programs. And the other piece that's I think kind of key is the fact that having access to patients when it comes to training is a very scarce resource, right? I cannot, if I'm a nurse, I cannot say, hey, bring me Douglas with a stroke symptom, right? So one of the pieces that we're doing right now that's pretty interesting is creating virtual patients with pre-built medical conditions so we can bring that into a more scalable training solution for all of these schools. So I'll let you go into a little bit on the pain points that you're seeing here, Greta.
Thank you. So there are about 126 graduate nurse anesthesia programs in the United States. And all of these programs, in order to be accredited, they have to incorporate simulation in their curriculum. So with me being a chair of the simulation committee for the American Association of Nurse Anesthesiology, last year, and we conducted a survey to all of the programs to establish the current state of simulation across the United States for the nurse anesthesia programs. So this is in print actually in our journal right now. This survey, which was showing what is currently happening and with recommendations in a form of white paper. So the main problem that we saw out of the 58 programs that responded across 38 of the states, number one problem with conducting simulation or having simulation embedded in the curriculum is lack of or insufficient number of faculty. As you can see, more than 50% of the programs have this issue. Inadequate funding, inadequate support personnel to run those simulation labs, to run the simulators. So when we are conducting high fidelity simulations, we need several people there involved. Also, inadequate simulation space, again, big problem, and inadequate faculty training. So part of those issues, they could be personal, they could be academic, but access to the simulation labs. Currently, at University of Miami, we do have a 5-story simulation hospital, really top of the line equipped hospital, 4 operating rooms on one of those floors. fully equipped. However, I do not trust with any of my students 24/7 to have access to those labs, because this is a multi-million-dollar equipment in there. And we want to make sure that students do have access to practice some of the skills or some of the scenarios that we teach them, either in off hours or in their own homes, or even when they're in clinical settings, but have time in between those cases that they could do those. The lab availability, the cost of participation in those labs. Again, it costs money to run the labs, to have people staffing the labs, to have money to maintain the equipment, which as soon as you buy $300,000 simulator, high fidelity simulator, 3 years later, contracts are expiring or things are happening. So also academically, the pace in changes in the healthcare are so fast. I mean, just as you guys all see it today, with the exhibitors here, what we are seeing is we don't print our medical books every year. It usually takes at least 5 years before the next version is being printed, right? The range of all the options now that are being available for patients and for all of the healthcare educators, that we have to be on top of all of these to teach the students so quickly, and also the complexity of our healthcare systems. Going back specifically for anesthesia, there was an article published in International Anesthesiology Clinics in 2020. The authors did put a lot of research there showing that virtual reality actually has demonstrated value in teaching skills, critical thinking, and which are part of the non-technical skills for our learners. However, there is a big gap for anesthesia in particular, as there is no currently virtual environments created for anesthesia learners. I'm talking nurse anesthesia resident, nurse anesthesia students, anesthesiology residents, also anesthesiology assistants, anyone that is training in those spaces. And we definitely need to expand in this area.
So our solution to all these pain points and all these challenges is a product that we call the Medicalverse. And the Medicalverse basically brings 3 key components that you are seeing here in terms of benefits, right? It brings the virtual simulation labs that allows us to eliminate all of these physical limitations that Greta was mentioning before. Also, it allows for faculty scalability. So when we create multiplayer or multi-user real-time environments where the professor and the students can come into real time, that just allows for the instructors to be able to have more sessions to train their students. And as I mentioned, the virtual patients, that's a big push on our end. We're already building a library of patients with different genders, different ethnicities, different age ranges. And they come in with previous medical conditions, like I mentioned before, so that they can train against an environment that's very similar to what they face in real life. This is a little video of what the Medicalverse looks like. You guys can come to our booth at 507 if you guys want to experience some of this work. So this Medicalverse is going to continue to grow into these big pods for different types of medical simulation training labs. This is part of our virtual patients inside of an operating room where we're doing a full intubation procedure that has both visual cues, and in the actual real virtual reality environment, they also have guided voice-guided instructions as well, so that the students can follow both of those, both the visual cues, the voice cues, and we also have a full analytics and metrics platform underneath, so we can capture any kind of interaction or even assessments within these environments. As I mentioned, the 3 components that we have is the secure content distribution platform. So even in this Medicalverse, we only allow students or instructors that have an authentication against that environment in order to provide a safe and secure environment for all the participants. Of course, the VR simulation labs, we continue to scale them. You guys are going to see a little bit of our product roadmap in a little while, and the analytics platform, which is becoming stronger and stronger from the point of view that we can grab analytics and data not only on the learners, but also on the content. And then this is our first product. This has been launched already. This product contains 5 different types of anesthesia labs. And I don't know if you want to talk a little bit about why you decided that this was the first kind of set of modules to go with.
If any of you haven't heard, but we had a COVID pandemic, and none of our students were allowed to go to the clinical settings or the hospitals anywhere, what the nation said, anywhere between 2 to 8 months. And these students needed to continue practicing and needed to know what's going on in the clinical environment. So the best way for us at this point was when we decided, well, let's show them what we don't even have in our operating rooms, simulated operating rooms in our sim hospital, and some of the equipment such as anesthesia depth monitoring, how to gauge your anesthetic gases when somebody's under general anesthesia, the fluid statuses, how to work with the normothermia equipment. These turned out to be one of the best ways that we were able to solve this issue for our students, so they still felt like they're in the operating room and learning how to operate this equipment and what is the meaning of it, how to tie it together. And from there on, we added a couple more, the intubation, the nurse.
Yeah. So this is the beauty about this. It's just not theory anymore, right? You have actual students going into an actual setting and actually working and learning through this environment. So I don't know if you want to say a little bit, because this is...
So this was the first, so we launched actually this product a year ago with Magic Leap goggles, which was not as good as the Oculus. We don't want to say anything against Magic Leap, we love them. However, we just launched this, and all the data we collected was with these students. So that's Daphne, one of my second-year students, and I was working with 2 of them that were working with the first-year students, solving faculty problems, right? And we were having 4 students at a time, and we were launching the product, so they were training how to use this. So this is only her second use, and how quickly and how smoothly she was able to operate everything. So what we were doing is, one faculty, we were projecting from her goggles on a big screen, and we were able to actually orient the rest of the students and to guide her how to proceed with some of those skills. So it's not that we're eliminating faculty use, but we are also standardizing. So faculty is there, we are giving real-time feedback on the skills, but at the same time, we are standardizing the process, because every faculty tends to teach their own way, how things should be done, because my way is the only right way, right? So we want to make sure that we're addressing those things, and we are standardizing the students' education, especially for new learners. And from there on, with adding the metrics that Douglas is mentioning, we can actually now track the performance of the learners. And as the American Academy of Colleges of Nursing is going toward competency-based education, this is how we are aiming towards solving a lot of those issues. How do we measure competency on so many skills that we have to teach the students?
So the beauty about this, so Greta conducted a study, and here are some of the kind of data. So it was 40 students, as you guys can see. This is a split. And then I'll let you talk a little bit about the results.
So the first-year students that we tested the application with, after 2 or 3 beta testing with the second-year students, we had now almost all of the students, their feedback is first about the Oculus, and they said they were quite user-friendly with the controls, the instructions, the sequence of actions. They all agreed or strongly agreed that it helped them learn how to use the equipment. The next one, yep. Thank you.
Sorry.
And the next one is, how is the environment? Is it realistic? They all agreed or strongly agreed that the environment was very realistic. Now the second those same students that were training in virtual reality, now they're in clinicals. So this month, actually this week, we're going to collect the next set of data, asking them how do they compare the virtual reality environment with now what they're experiencing clinically. So we want to look at, and how fast is it taking them to orient themselves in this clinical environment. Another thing is we're also, as faculty and as in academia, we want to evaluate also the fact that a lot of people complain about virtual reality making them nauseous or experiencing some physical side effects. So we use a standardized tool that measures physical responses to learners or users. The good part is more than half of our learners did not experience any side effects. The thing is, we did not differentiate if one of them experienced more than one kind of a effect. So this is just the number, the count there. The second most common was blurred. So first is no effects. The most common side effect was blurred vision. About 7 students complain of that. And again, I wanted to make sure that this is kind of student-led for cases when we don't have faculty to constantly be explaining somebody how to use the goggles. We wanted this to be very kind of a natural felt experience. So if nobody's there to tell you how to use it, what would you do? How long will it take you to self-orient based on just the quick steps that we have embedded in the program? So this could be very easily fixed afterwards. Now we had some students, couple of them said feeling unease, couple of them feeling a little disoriented, and then warm, hot temperature, again, dizziness. But in general, here and there, very, very small percentage, like less than 5% of the students complain of any physical side effects. Would they recommend this for the next cohort or for other learners? They all said yes. They would strongly or somewhat agree that they would recommend this application. Now, additional comments, how do we gauge what we develop next is based on, on our own students' comments. They love the application. You all see here the type of audience we have. We are also people that like to see things, to try things, to experience things, and that's exactly what the learners want to do, a newer generation. They love it, they're bragging about it, and we want to stay there. Also, they tell us what else they want to see. So they want to see a lot of additional things that hopefully we'll start working with Douglas' team.
Very soon. So what's next with this specific solution? We're starting to basically focus specifically on the areas where there is the larger shortages of medical professionals and where is a huge demand. The second piece is, of course, we're going to continue to work with SMEs like Greta and SMEs across different areas in order to expand the different things that we need to build in terms of simulation labs. And the other thing that's kind of interesting, we've also been discussing with some larger medical companies. We don't want to be a Decentraland or anything like that. That's not our goal or our roadblocks. But because we build this ecosystem, some of these companies are interested in using already all of these environments to actually deploy their own training environments, whether it's for equipment, for simulations, and for training. We already have a product roadmap plan for the next 12 to 18 months. We're going to be focusing on critical care management. A lot of people are talking around ventilation as one of the things that ventilator management and ventilation is one of the things that is critical for that. Critical basic skills, I mean, we've even had a lot of discussions with Greta and other organizations around how even a lot of nurses don't know how to put an IV, and that causes a lot of sometimes pain for their patients. You know, there's been some more serious problems there. And then critical emergency scenarios. I think, you know, I mean, the opioid overdose assessment, we think that's such a critical thing with the environment that we're living, where there is so many issues around, you know, kids overdosing, unfortunately, with drugs, right? Also, one of the things is, of course, scaling the patient scenarios. That's another big thing, not only building all of these different virtual patients with different genders, ethnicities, and so on, but also all of the different critical medical conditions embedded into those virtual patients is going to be critical. We see tactile as being the next level of actual immersion when it comes to the medical field. And this is a Tesla suit glove. I don't know if you guys have seen it. You guys have seen haptics in here. We're hoping that these technologies evolve faster, hopefully, than that they have been, because we see tactile experiences being critical. And then, of course, 5G. I think when Greta was mentioning about real-time interactions between doctors, instructors, and students from across anywhere in any remote location, 5G is going to play a critical role for us to be able to deliver higher levels of real-time interaction and collaboration, right? And then, so with that, thank you guys so much for listening to us. If any of you guys have any questions, you guys can step up to the microphones, and we'll be more than glad to answer them.
Hi, that was a great talk.
Thank you.
Thank you.
I have a question regarding some of the studies that you ran afterward. I noticed that they have a lot of opinions, like did this improve your previous learning? Did you like it or did you not like it? Did you run anything that was more metrics based, as say anything double blind, as for example running a cohort with a VR experience and then running another one without a VR experience and then seeing where they would succeed and where they would fail?
Great question, thank you. Unfortunately, when we have students, we need to offer the same learning experience to all of them, so I cannot do really blind studies. But what we are looking at metrics is students from the previous cohort that did not have this kind of immersed VR experience. How was their performance the first month when they started clinical experiences compared to these students now? So I'm looking at their daily evaluations. So exactly what you said, I can do double blind, but I could do something like comparing from the previous cohort. And then eventually we all want to see how this translates to clinical experience, to clinical knowledge. How can we decrease the steepness of this learning curve so it doesn't take 47 intubations before somebody could say that they're proficient at this level without broken teeth, cut lips, and stuff like that. So how do we do that is by looking at those evaluations that the students receive every day when they go to clinicals, and then compare to when they had number of times that they could practice the skill, and when they went there, how many intubations that they had to do before they were already proficient, they felt proficient, or whatever their evaluations were. How many attempts did it take, what we say, for first-time intubation, for successful intubation? So this is one of the things for intubations, but also we were looking at some additional metrics, really how quickly they could set up the operating room between cases, because in the ORs, time matters. 1 minute of operating room time is anywhere between $100 and $150 per minute. So we want to decrease this time between cases, so how quickly they could take one patient out to recovery room, set up quickly the stuff for the next patient to come in, and a lot of this equipment that they have to work with, being more proficient on time, also what we're looking at.
So do you see this prep time now that you have the VR simulations going down, and
yes,
amount captured also shortening, or people having more retainment?
Yes, and I haven't learned this kind of data. I haven't run any of this data yet, because this has to come from the hospital. They will have to be willing to share some of this with us, and they don't always do that. But we are looking at, again, what we can measure between preceptors and students and feedbacks. This will be the next steps.
Mm-hmm. Thank you.
Thank you. Thank you.
Anyone else? No? Thank you guys so much. We really appreciate you guys being here.